Hi everybody, Dr. Daniel, and today I'm talking about are migraine and generalized anxiety disorder related? Everybody on earth has some degree of stress or anxiety. They might not be able to talk about it or identify it, but anxiety is part of the universal human condition. As a practicing neurologist and headache doctor, I've learned that many persons, when asked if they were anxious or stressed, would answer no. But their stress would be revealed later in the interview by complaints of poor memory, trouble sleeping, or constant pain in the back of their neck, jaw, or shoulders, which are anxiety symptoms. People may say that their boss is a pain in the neck, a symptom common with the muscle tension part of generalized anxiety disorder, which includes tension in the neck and shoulders. The boss is the problem, but the patient gets the pain in his neck. This is a backward way of a patient saying they're stressed, especially by their boss, who may be demanding and strict. Half of persons with trouble sleeping or insomnia have GAD, the most common cause of sleeplessness. GAD is generalized anxiety disorder. Some people think that they have Alzheimer's, dementia, because they can never remember things well. Yet they test well cognitively and really just have poor concentration, another cardinal GAD symptom. Muscle tension means it relates to time pressure or the feeling of having to work under the pressure of the clock to get a project done. Such a person may feel he doesn't have time for himself or for lunch, so he misses a meal and gets a hungry headache. All of these scenarios describe anxiety situations. Migraine and generalized anxiety disorder are 40% comorbid, a term that means these two medical conditions occur more often than by chance. 40% comorbid means that these two medical conditions occur together 40% of the time. Migraine is a complicated, disabling medical problem that comes with one-sided moderate to severe headaches, which are throbbing and associated with sensitivity to light and noise and nausea and vomiting. Generalized anxiety disorder is commonly associated with patients who perceive stress or tension in their lives, who don't sleep well, and complain of chronic tightness in the muscles of their neck, back, and shoulders. According to the Diagnostical Manual of Mental Disorders, 5th edition, the DSM-5, generalized anxiety disorder is defined as a patient complains of symptoms of excessive anxiety or worry about a variety of topics, events, or activities. The worry should be about employment or the patient's own or a family member's health. The worry is difficult to control and not related to a threat or a prevalent risk. Patients with GAD spend a lot of their daytime worrying about something. The patient's anxiety and worry come with at least 3 of the following symptoms. The symptoms occur half the time during the past 6 months. Half the time in the last 6 months. The symptoms cause significant distress or social impairment. The patient has at least 3 other ancillary symptoms, which are restlessness or mental tension, fatigability or easy tiring, and poor concentration, as if the mind goes blank, irritability, increased muscle tension and soreness in the neck, shoulders, jaw, or teeth, grinding or bruxism, trouble sleeping, which may come with difficulty falling asleep, maintaining sleep, nighttime restlessness, or unsatisfying sleep. All right, so migraine without aura is a headache disorder, and you have to have 5 attacks fulfilling the features of it lasts 4 to 72 hours. The headache has at least 2 of the following characteristics, or 4 of them. It should be one-sided, it should be pulsing in quality, and moderate to severe in pain intensity. That is on a scale of 1 to 10 of pain. Migraine should be 6, 7, 8, 9, like that. And should be aggravated, causing avoidance of routine physical activity, like they go down with a headache. They don't like to walk. They don't want to climb stairs. And during the headache, they have at least one of the following symptoms, either nausea or vomiting, sensitive to light or sound. Tension type headache is different. To make a diagnosis, you have to have 10 episodes, headaches that last 30 minutes to 7 days. And the headaches has at least two of the following characteristics. It's bilateral in location, that means both sides of the head. It's pressing or tightening or non-pulse style quality. It's mild to moderate. Again, on a scale of 1 to 10, it goes to 5, but no higher. It's not aggravated by routine physical activity such as walking or climbing. Nosology. A migraine without aura was previously called common migraine, while migraine with aura was called classical migraine. Many patients mistakenly believe unless one has visual type auras, like seeing holes, spots, or zigzag lines, the diagnosis is not migraine. That's wrong. Only about 30% of persons who have migraine have an aura with a visual aura, the other 70% don't. Many online writers erroneously discuss muscle tension as part of migraine, yet features of that go with tension-type headache. Tension-type headache has been called muscle contraction headache, psychomyogenic headache, stress headache, ordinary headache, essential headache, idiopathic headache, and psychogenic headache. Generalized anxiety has been called stress and nervousness. So epidemiology and prevalence. Migraine is an extremely disabling condition and first in frequency of all disabling neurologic diseases. Almost 3% of worldwide disability attributable to a specific disease in terms of years lived with a disability is due to migraine. Migraine is a very disabling condition. 25% of women and 6% of men have migraine. The overall prevalence of migraine is 12%. 40 to 50% of Americans living with migraine also have anxiety. Persons with migraine may be up to 5 times more likely to have anxiety than persons who do not have migraine. Migraine is a multifactorial disorder which links with genetic, hormonal, environmental, dietary, sleep, and psychological aspects differently in each individual. Migraine is a biobehavioral disorder. Generalized anxiety disorder is highly prevalent. In the United States, the lifetime prevalence of GAD is estimated to be about 5%, and the current prevalence to be about 2 to 3%. The National Comorbidity Survey conducted from 1990 to 92 found that lifetime prevalence rates for any anxiety disorder were 30.5% for women and 19.2% for men. The reference there is Kessler et al., 1994. Preference rates were also higher in women than men for each anxiety disorder examined, including panic disorder, agoraphobia, specific phobia, social anxiety disorder, generalized anxiety disorder, and post-traumatic stress disorder. The course of GAD is chronic and can be worsened by poor family relationships, comorbid personality disorders, and comorbid depression. A 2017 Canadian Population Health Survey showed that 6% of people with migraine had experienced GAD in the past 12 months, compared with only 2.1% of those without migraine. This study confirms the findings of previous research regarding the strong association between migraine and GAD. Anxiety disorders are the most common psychiatric conditions in the United States, affecting more than 18% of the adult population each year. Generalized anxiety disorder, characterized by excessive and persistent worry accompanied by physical symptoms, affects an estimated 3.1% of these adults. The anxiety disorders that have been shown the strongest associated with migraine are GAD, obsessive-compulsive disorder, and panic disorder. Studies have shown that people with GAD may be more likely to develop migraine, and that those with migraine may be at higher risk for GAD. Untreated anxiety disorders, such as GAD, may contribute to shifting from episodic migraine, that is fewer than 15 migraines per month, to chronic migraine, which is 15 or more migraines a month, 8 of which have migraine features. Many times, this shift occurs because overtreating their headache with painkillers, resulting in medication overuse headache. These people are doing that, and they have developed chronic migraine. Studies in families and identical twins have found that generalized anxiety disorder is about 32% hereditable, indicating that although genes contribute to vulnerability, environmental factors play a larger role. Epidemiologic studies report that women account for 2/3 of those affected. Tension-type headache is a highly prevalent condition that can be disabling. Published estimates of the prevalence of tension-type headache vary over a wide range from 1.3% to 65% in men and 2.7% to 86% in women. Probably the terms there are not straight because those results sound so difficult. But anyway, that's what's published. Anxiety can, after some time, or in case of major anxiety, lead to tension-type headache. If you're anxious, your entire body tenses up. Your body also becomes exhausted. This can cause tension, especially tension in the neck, to remain in the body. All right, the genetic link. Migraine is a complicated genetically related neurovascular disorder which clusters in families. Specific genes for hemiplegic migraine have been determined, but for the usual occurring types of migraine, which are migraine without aura and migraine with aura, the best that can be said now is that migraine is a polygenic condition and that there are many genes there, but it's not one specific one. Generalized anxiety disorder is related to migraine 40% of the time, and GAD especially relates to chronic migraine. The age affected for GAD, migraine, different conditions, migraine usually starts in the teens, early 20s. It's the most common in the 30 to 40 age group. At least 90% of people with migraine experience a first attack of migraine before the age of 40. Migraine generally improves with aging, usually after the age of 50. GAD usually appears from young adulthood through the mid-50s. One study reported that only 3% of patients first develop generalized anxiety disorder after age 65. The disorder, GAD, tends to be chronic, however, with symptoms that fluctuate in intensity over time. The typical life stresses that occur with old age, such as death of a loved one or personal illness, may cause symptoms to flare up. Neurologic workup for these conditions should certainly be done, and patients with migraine or generalized anxiety disorder need to have medical tests to rule out possible medical conditions. A normal MRI scan of the brain with and without contrast will usually eliminate concerning brain disease and can be very reassuring to the anxious migraine patient. Blood work such as a CBC, sed rate, urinalysis, thyroid panel, and electrolytes should be done. Common medical problems that may mimic anxiety, including heart disease, diabetes, and especially thyroid problems like hyperthyroidism. Respiratory disorders such as chronic obstructive pulmonary disease, COPD, and asthma, and drug misuse or withdrawal can also interfere here. The duration of attack. A single migraine attack, by definition, lasts 4 to 72 hours. This time element gets confusing with overtreatment with painkillers or headache medicine, which may lead to medication-induced headache, and chronic migraine, so that headaches occur every day or very frequently. In generalized anxiety disorder, the person has persistent worry or anxiety that lasts at least for several months. The Diagnostical Manual of Medical Disorders set the minimum to at least 6 months. Prognosis. The prognosis of these conditions is directly related to patient compliance and appropriate medical treatment. Migraine now has a number of very competent acute therapy and chronic treatment options that patients may pursue. Treatment with triptans, such as sumatriptan at the onset of a migraine, produces a headache-free state for 70-80% in 2 hours for patients. The new CGRP drugs used for migraine prevention, such as Aimovig, and there are 3 others, which is delivered by subcutaneous injection, and one of them is an IV treatment each month, can reduce migraine attacks to like 50% in half of patients, 75% in a quarter of patients, and really 100% reduction in another quarter of patients. Generalized anxiety disorder may be treated by psychiatric consultation and the judicious as needed short-term use of one of the benzodiazepine drugs, such as Xanax or Klonopin. The patient may be treated with one of the SSRI groups of drugs, such as Lexapro, given for chronic treatment as 1 a day. Patients should be instructed in and do cognitive behavioral therapy, CBT, which is a non-drug treatment helpful for anxiety. Aerobic exercise should be advised. It's great for anxiety conditions. And then all people who with these conditions should talk with their spouse, their girl or boyfriend, or counselor, their priest, preacher, or rabbi. Talking with someone is very helpful for anxiety. Well, what about the other anxiety disorders? Do they relate to migraine? Panic disorder is also comorbid with migraine. 40% of patients with panic disorder have migraine, and since many people have a simultaneous attack of migraine and panic attack that happens at the same time, I've seen many of these individuals. Many of these persons are bothered by chest pain and body tingling. When it comes on there at their office, suddenly they get it and they don't know why. They go to the emergency room immediately. Obsessive compulsive disorder, also known as OCD, is aligned with anxiety disorders, also especially chronic migraine due to medication-induced headaches, called MOH. People with medication-induced headache accelerate their genetically inherited migraine headaches by overtreating with painkiller medications. Most of them end up with prolonged, bothersome, and disabling migraine headaches. Medication-induced headache may be treated by headache specialists with education to not overtreat and to limit all over-the-counter painkillers, triptans, and ergotamines to no more than 2 treatment days a week. And a closing statement from me would be there is no place for the use of opiate narcotics or butalbital in the treatment of migraine or any other headache. So I hope this discussion has been helpful to you. Please click on the like and subscribe down there, and I will see you again on my next talk.